It's time for the 3-question warm-up for Cardiovascular 1. Let's get going. What marker of inflammation produced by the liver and within atherosclerotic plaques is a strong predictor of MI risk? So this is going to be the C-reactive protein, sometimes we refer to it as CRP. And as a minor clinical pearl, be sure to order the high-sensitive CRP if you're looking for evidence of atherosclerosis. So CRP is an acute phase reactant like cedrate, so just about anything that causes inflammation will elevate the CRP, like infection or inflammatory arthritis or almost anything. Next question. What is the classic presentation of asyringomyelia? What malformation is associated with asyringomyelia? So there's going to be bilateral loss of pain and temperature sensation. And you could also potentially compress the motor cell bodies of the anterior horn and get weakness and atrophy of the hand muscles as well. Now there will be bilateral loss of pain and temperature sensation in the upper extremities because the most common location of a syrinx is that C8 to T1 area. Now, a syrinx destroys the crossing spinal thalamic tract fibers. And then, of course, here the last part here, what is the malformation? This is the Chiari malformation. Next, a 28-year-old woman is involved in a motor vehicle accident. She initially feels fine, but minutes later she loses consciousness. A CT scan reveals an intracranial hemorrhage that does not cross suture lines. What bone and vessel were injured in the crash? So this is a classic epidural hematoma, which is commonly due to rupture of the middle meningeal artery caused by injury to the temporal bone. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to kick off the cardiovascular section by discussing the embryological development of the heart and also the fetal circulation. Now, heart embryology is kind of confusing because the path of blood is all different from the adult heart. You've got blood being shunted in all sort of crazy directions, and there's structures that appear and disappear and change shape. They've all got names that sound like magic spells from Harry Potter, stuff like truncus arteriosus. So let's begin at the beginning. The heart starts out as a simple tube. It's just an enlarged portion of a blood vessel, a long tube. And then this tube starts folding up on itself, kind of like a balloon animal. So the first thing that happens in order to convert this tube into a 4-chambered heart is to fold the tube into an S shape. And this S is oriented so that the distal part, which is eventually going to become the atria, is posterior, and the proximal part, which will become the ventricles, is anterior. So when the tube folds, it goes from this to this. And then the atrial chamber, which is now posterior, is going to grow and eventually incorporate the superior vena cava and the pulmonary vein, which are in the back of the heart. So that gets us to this. And then we need to start building a septum to divide the left heart from the right heart. And if you look at number 4 in your study guide, it says, outline the pathway by which the heart tube forms the atria of the 4-chambered heart. Then it talks about the tube that folds into an S shape. I'm not going to read all this to you, but we're going to talk through each of these steps, and you can refer back to the study guide later when you're reviewing this. Heart embryology is just complicated enough that you're probably going to need to take a couple of passes at it before it starts to sink in. But let's look at the heart in cross-section and talk about how the atria form. You start with sort of this big, open, primitive atrium, and the primitive ventricle is down below. And right in the middle is something called the endocardial cushion, which acts as a kind of anchor for the atrial ventricular septa to form on. We'll talk about the endocardial cushion a little bit later. So we need to construct a septum that separates the right atrium from the left atrium. But we also have to leave some kind of opening so that during the embryonic and fetal period, blood can bypass the pulmonary circulation and go right from the venous side to the arterial side. So the first thing that happens to construct this septum is called the septum primum, which grows from top to bottom toward the endocardial cushion. As it's growing, we see this gap or ostium between the septum primum and the endocardial cushion gradually shrinking and shrinking, right? That gap is called the ostium primum. As the septum primum grows, the ostium primum shrinks. And before the septum primum actually reaches the endocardial cushion and forms a solid wall, it starts to develop some perforations superiorly, again to allow blood to flow from right to left. Then as the septum primum reaches the endocardial cushion and obliterates that ostium primum, these perforations kind of merge, and we now call this the ostium secundum, or sometimes the foramen secundum. So far, so good. The next thing that happens is that a second septum starts to grow, which we call the septum secundum. And again, as it develops, it leaves a gap or foramen to allow shunting of blood from the right to the left. And this foramen is called the foramen ovale. Let's hold it right there for a second and look at number 5 in the study guide. What divides the right and left atria? Again, it's the septum primum and the septum secundum. And then number 6 says, how is blood shunted from the right atrium to the left atrium in the embryo? That's through the foramen ovale and the ostium secundum. Again, you need that right to left shunt during development. We're going to see exactly why when we talk about the fetal circulation in a little bit. So the foraminal valley and the ostium secundum is where this blood is flowing. So now we're ready to go back to our cross section of the heart and pick up where we left off. Here's the septum secundum starting to form. And up here you can see the perforations in the superior part of the septum primum just about to completely merge to form the ostium secundum. Now don't get confused. The ostium primum and the ostium secundum both develop in the septum primum. Don't think primum, primum, secundum, secundum. That's not right. Now here, the septum secundum has completely formed, and you can see the foraminal valley in the inferior part of the septum secundum. And then in the superior part of the septum primum, you have the ostium secundum. Those two openings don't overlap. You can see how blood comes from the vena cava into the right atrium, and then it goes through these two gaps in the developing septum and into the left atrium so that it can be pumped to the rest of the body. Very, very important. It's important because if something goes wrong with this process, you can end up with a heart defect called an atrial septal defect, or an ASD, or in layman's terms, a hole in the heart. You're going to review the clinical aspects of an ASD in the next video on congenital heart diseases. But for now, let's look at number 7 in the study guide. Number 7 says, what are the 3 possible causes of an atrial septal defect? Now, this list isn't super high yield, but it's nice to understand conceptually what's going on. The first possible cause of an ASD is that the ostium secundum gets too big and it overlaps the foraminal valley. The second possible cause is an absence of the septum secundum. And the third possibility is that neither the septum secundum nor the septum primum develop. Then number 8 says, what structure grows to close the opening between the atrial chamber and the ventricular chamber into 2 smaller openings? Now this is the superior and inferior endocardial cushion. So we saw that before, right in the middle of the heart. And number 9 says, what genetic abnormality is commonly associated with endocardial cushion defects? This one's important to know for sure. It's trisomy 21, or Down syndrome. Now let's talk about the development of the ventricular septum. So number 10 in the study guide says, outline the pathway by which the ventricles and their outflow tracts are separated. Now, this is a little more straightforward conceptually. The ventricular chamber, again, is lying anteriorly in this S-shaped heart tube. And there's a muscular septum that forms, this time from the bottom up, growing up toward the endocardial cushion, and that septum begins to divide the ventricles. Then there are these ridges of tissue that start forming inside the truncus arteriosus. And these ridges are called truncoconical swellings. These ridges grow toward each other until they meet in the middle, and they sort of do a 180-degree spin move to form what we call the spiral septum, or the aorticopulmonary septum. And remember, the cells that form the truncus arteriosus and this aorticopulmonary septum come from neural crest cells. Remember, neural crest cells migrate from the neural crest all over the body, and they're involved in these crucial intricate developmental processes, establishing order. Then the most inferior portion of the spiral septum meets up with the muscular ventricular septum to divide the ventricles and form the aorta and the pulmonary arteries. Again, that 180-degree spin move is what's so essential here. Now, number 11 lists some defects in the development of the spiral septum. We've listed 6 developmental defects for you, but the main ones I want you to know are tetralogy of Fallot, persistent truncus arteriosus, where you only have partial spiral septum development, and then transposition of the great vessels, where the right ventricle is pumping blood into the aorta and the left ventricle pumps blood into the pulmonary artery because that 180-degree spin didn't take place. Now, there are some other pathologies that you can see, but those are the 3 main ones I think you ought to know. Again, you're going to review all those in detail in Cardiovascular 2 video. But when you see them again, I want you to remember, that was a problem with the development of the spiral septum. Then number 12 says, describe how the ventricles are remodeled in order to form the atrioventricular valves. So basically, the myocardium is going to erode, and the ventricles enlarge as a result. So you start with a rather narrow ventricular lumen, and then the myocardial cells kind of erode away, and that's going to enlarge the lumen. Then residual mesodermal tissue becomes fibrous, and it forms the chordae tendineae, and then the papillary muscles and the AV valves are able to form. Now, let's go back to our original primitive heart tube, and let's see what each piece of that tube is eventually going to become. First of all, you have the truncus arteriosus, which we said gives rise to the great vessels, the proximal aorta and the proximal pulmonary trunk. The bulbus cordus gives rise to the outflow tract of both the right and left ventricles, the smooth parts of the ventricles. The primitive ventricle gives rise to the trabeculated parts of the left and right ventricles, which are the muscular portions of the ventricles. The primitive atrium gives rise to the muscular or trabeculated parts of the left and right atria. Then the sinus venosus is going to be divided into the left horn and the right horn. The left horn gives rise to the coronary sinus, and then the right horn gives rise to the smooth part of the right atrium. Another topic to review in the embryology of the cardiovascular system is the aortic arch derivatives. Now, when we talked about the branchial apparatus and the branchial arches back in neurology, we said that each branchial arch has an artery. Now, those are the aortic arches. There's these interconnected arteries that come off of the truncus arteriosus, and they supply the branchial arches. And just like the branchial arches and clefts and pouches all went on to develop into something else, each of these aortic arches develops into something else. So we're going to walk through all of them, but I'm going to tell you up front, the ones that you're most likely to be tested on are the third and fourth aortic arches. So the first aortic arch becomes part of the maxillary artery. Remember, the first branchial arch contributes to the mandible and all those jaw structures. And here, the first aortic arch is forming the maxillary artery, which takes off from the external carotid right behind the neck of the mandible. The second aortic arch becomes the stapedial artery and the hyoid artery. You can remember that the second branchial arch gives rise to the stapes and the stapedius muscle, and then also part of the hyoid bone. So those artery names make some sense. The third aortic arch, and this is the one I want you to focus on, the third arch becomes the common carotid artery and the proximal part of the internal carotid. Then for the fourth aortic arch, we have to talk about the left arch and the right arch separately. So remember, these are paired arteries. So the left fourth arch becomes the arch of the adult aorta, which is easy to remember because the adult aorta, the arch is on the left side of the chest. And then the right fourth arch becomes a proximal part of the right subclavian artery. And the sixth aortic arch becomes a proximal part of the pulmonary arteries and the ductus arteriosus. And maybe you remember we said there's also a fifth arch that develops early on, but it degenerates and never really develops into any adult structures. So those are the aortic arches. Make sure you know the derivatives of the third and the fourth arches, but the rest of them are certainly fair game too. Now we're ready to talk about the fetal circulation. So I'm going to walk you through the flow of blood in the fetus, starting at the most highly oxygenated vessels, and we're going to work our way to the least oxygenated vessels. We're going to look at the areas where the highly oxygenated blood mixes with the less oxygenated blood, and we'll also talk about the transition from the fetal circulation to the mature circulation, which occurs shortly after birth. First of all, which vessel carries oxygenated blood from the placenta to the fetus? The umbilical vein or the umbilical arteries? It's the umbilical vein. Remember, veins are defined by the fact that they carry blood back to the heart, not by whether they carry oxygenated or deoxygenated blood. So the umbilical vein carries oxygenated blood from the placenta, and it first goes to the liver. Now in the liver, you have mixing of oxygenated blood from the umbilical vein with some of the deoxygenated blood from the lower extremities, and that takes place at the ductus venosus and then in the inferior vena cava. So here, the order of oxygenation from highest oxygenation to lowest is the umbilical vein, the ductus venosus, the IVC, and then the right atrium. Now in the right atrium, the blood can take one of two pathways. It can either pass through the foraminal valley and go directly to the left atrium, or it can go through the right ventricle into the pulmonary artery. So let's talk about this pulmonary artery pathway for a second. From the right ventricle to the pulmonary artery, here again there are two more ways the blood can go. It's like choose your own adventure if you're a red blood cell. The blood can either go to the lungs, just like in the adult circulation, or it can go through the ductus arteriosus, which is a fetal connection between the pulmonary trunk and the aorta. So a lot of the blood that took the pathway through the right ventricle and the pulmonary trunk is still going to bypass the lungs and go directly into the systemic circulation. But let's say that you're a red blood cell that did go through the pulmonary artery to the lungs. Well, when you finally make it to the left atrium, you're going to meet up with some of those shortcutters that came from the right atrium directly through the foraminal valley. So there are two different pathways to the left atrium. But however the blood gets to the left atrium, from there it goes to the left ventricle and through the aorta. And again, this blood going through the aorta is going to meet up with the blood that came through the ductus arteriosus. And then all of that is going to go from the aorta out into the rest of the systemic circulation. And part of that systemic circulation goes through the umbilical arteries back to the placenta to drop off CO2 and pick up more oxygen and nutrients. So that's fetal blood flow. So again, just to reiterate, the areas where you have shunting are the ductus venosus in the liver, the foraminal valley between the left and right atria, and the ductus arteriosus between the pulmonary artery and the aorta. So make sure you know all three of those shunts. So what's going to happen at birth that causes all this to shut down? Basically, it's respiration. The baby starts breathing, and that closes down the fetal circulation and creates an adult circulation. So when you take a breath, the intrathoracic pressure decreases. And this decreases resistance in the pulmonary vasculature. So you expand the pulmonary vasculature and it creates a little vacuum that starts to suck blood from the right side of your heart. So now more blood is entering the pulmonary artery. That also means that more blood is returning to the left atrium via the pulmonary vein. So decreased resistance in the pulmonary vasculature eventually causes an increase in the left atrial pressure. So now the left atrial pressure is higher than the right atrial pressure. And that causes the foraminal valley to close. That higher left atrial pressure basically pushes the septum primum up against the septum secundum so that the passage between the atria is now closed. Now eventually those two septa are going to fuse, but until then, the increased left atrial pressure just holds them together. So now you have the highly oxygenated blood coming from the lungs and the pulmonary veins into the left atrium and into the left ventricle and out into the aorta. And that highly oxygenated aortic blood is going to cause the ductus arteriosus to close. Now, if that doesn't close, we call it a patent ductus arteriosus, or PDA. And you're going to go over that in the next video with the other developmental pathology. But just one FYI, it's fairly common to hear a murmur of patent ductus arteriosus in the first 24 hours of life. You're not going to panic about it. You're just going to give the baby a little time before you do anything about it, because it may still close on its own. And then occasionally, if there are significant cardiac anomalies and you want to keep the ductus arteriosus from closing, you could give prostaglandins to help keep it open. So prostaglandins dilate vessels. They keep vessels open. And if you needed to close the ductus arteriosus, you would give an NSAID, like indomethacin, which inhibits prostaglandin synthesis and closes vessels. All right, that's it for the fetal circulation. So go ahead and go through the end of session quiz, and then we'll go through the answers together. All right, first question. Which embryologic structure of the heart gives rise to each of the following adult structures? So the ascending aorta and the pulmonary trunk come from the truncus arteriosus. The coronary sinus is derived from the left horn of the sinus venosus. The superior vena cava comes from the right common cardinal vein and the right anterior cardinal vein. The smooth parts of the left and right ventricle come from the bulbus cordis. The smooth part of the right atrium comes from the right horn of the sinus venosus. The trabeculated parts of the left and right atria are derived from the primitive atria, and the trabeculated parts of the left and right ventricles are derived from the primitive ventricle. Next, what structure divides the truncus arteriosus into the aortic and pulmonary trunks? And what's the cellular origin of this structure? So this is the spiral septum, or the aorticopulmonary septum. And again, this is a neural crest derivative. Next question, which fetal vessel has the highest oxygenation? So again, you've got to know the order. The highest oxygenation is found in the umbilical vein, then you go to the ductus venosus, the inferior vena cava, and then the right atrium. And then you start getting into the choose your own adventure stuff. So the umbilical vein is the fetal vessel that contains the most highly oxygenated blood. Next, what causes the ductus arteriosus to close? It's the infant's breathing and the increase in oxygenated blood in the aorta, and that leads to decreased prostaglandins and closure of the ductus arteriosus. And the last question, what causes the foraminal valley to close? It closes because of decreased pulmonary vascular resistance when the newborn starts breathing, and that leads to higher left atrial pressure, and that pushes the septum primum against the septum secundum. All right, that's it for Cardiovascular 1. See you next time. Sinus venosus, bulbus cordis, ductus arteriosus.